Started. Good morning and welcome to How We Cope, addressing barriers to healthcare for Black older adults. We thank each of you for coming and trust that our time together will be beneficial. Special thanks to our moderator and panelist. This event is co-sponsored by Whole, We Heal Ourselves Through Love and Empowerment, and the Racism-Based Violence, Injury, and Prevention Lab of Boston College. We are all in for a treat. We know that watching our loved ones age can be frightening. Thinking about aging ourselves can be frightening. And so we want to give some clarity and answers to the questions we may be scared to ask, right? Knowing that old age is not promised to any of us. Long life is a gift and often comes with challenges, especially when we aren't prepared for it. So this is our opportunity to get prepared. Knowledge is power. So we have assembled a panel of experts, particularly Black experts who can really speak to our experience, to share from their areas of research and experiences to learn about everything from nursing homes to palliative care, more questions to ask medical providers, to where and how to make a report if you feel you are not being treated properly. We are all here to learn, so please, please, please do not be shy with your questions. Please use the chat on Zoom or the comment boxes on YouTube to send any questions you would like to ask of the panelists, and we will do our best to include that in today's discussion. I want to take a moment to remind each of us that knowledge without application is wasted. So please be brave, put this information to use for you and your loved ones. And with that, I will turn it over to our moderator, Christopher Baidu, a doctoral student at Boston College School of Social Work. Thank you.
Thank you, Shamika. I am happy to be here today. As Shamika said, I'm a PhD student at Boston College School of Social Work. I also work in the Boston College Racism-Based Violence, Injury, and Prevention Lab. I'm excited to moderate today's event. It is my pleasure to introduce our panelists, who are Dr. Karen Bullock, Mildred Lewis, and Dr. Tamron Gray. I'm going to ask each of our panelists to tell you a little bit more about themselves by sharing their titles, their institutional or organizational affiliations, and areas of expertise and/or research. Let's start with Dr. Bullock.
Good morning, everyone. I think it's morning everywhere, irrespective of what time zone you might be logging in from. I'm Karen Bullock. I am the A. Heron Professor of Social Work at Boston College School of Social Work. I'm delighted to be a part of this panelist. I'm trained as a licensed clinical social worker with more than 30 years of practice experience. And my practice focuses on older adults. And over the last 15 to 20 years, I've been focused in the area of hospice, palliative care, or serious illness care. And my research and practice is primarily intended to address health equity. Again, thank you and welcome, everyone.
Thank you, Dr. Bullock. Let's go to Dr. Gray.
Hi, good morning, everyone. I'm delighted to be here today. It is a privilege to have this conversation with you all. So my background is that I am a oncology and bone marrow transplant nurse by training, and currently a palliative care and health services researcher at Dana-Farber Cancer Institute and Harvard Medical School, where I focus on supporting families who are facing serious illness diagnoses. It's a delight to be here today.
Thank you, Dr. Gray. And Mildred.
Hello, can you hear me? Can you hear me?
Yes.
Oh, hello, everybody. I am Mildred Lewis. I am an MSW, LCSW graduate of Boston College School of Social Work. I'm currently a director of social services at a nursing home. I have been working in the field for almost a decade now. Thank you. I am here to share my experience and knowledge about aging in the community, as well as in facilities within Massachusetts.
Thank you, Mildred. We've asked each of our panelists to prepare approximately 10-minute presentations about topics within their areas of expertise or research that are specifically related to healthcare for Black older adults. After the presentations, we would like to facilitate some question and answers from you, the audience. So please feel free to post your questions in the chat. We will get to them after the presentations. So let's start with these 10-minute presentations. We'll start with Dr. Bullock.
Thank you very much. I'll acknowledge that I didn't prepare any slides. I hope everyone is okay with just having a conversation. I'll start by, I guess a good entry point for me is to think about my community-focused research, and I'll share a little background about how and why I transitioned from more inpatient and outpatient practice to more community-focused practice. My mother was diagnosed with metastatic lung cancer, stage 4, when I was a doctoral student. And much of what's in the literature talks about how it is that women tend to be caregivers. And doing this research and focusing on older adults, I was reading and learning about the different family structures and the way in which communities join together, especially in Black communities, to support one another, and that older adults always had a prominent role in families. And this may be an overstatement for some people, but certainly what I was reading in the literature was bearing out in my own community. And so when my mother was diagnosed with metastatic lung cancer, I was a doctoral student at Boston University, and my mother lived in North Carolina. I was born and raised in North Carolina, as we say. But as the only daughter, I was the one going back and forth with my mother to doctor's appointments. One of the good things was that my mother told me as soon as she got the diagnosis that the doctor told her there was a spot on her lung and she didn't know what it was. In many communities, I know our health information is so protected and we don't necessarily feel comfortable sharing it with loved ones, sometimes because we don't want them to worry, or we are just private in nature about our healthcare. I know I didn't know very much about the health history of my relatives. And whenever I would go for a medical appointment, general medical appointment, they'd ask, oh, is there a history of XYZ illness in your family? And I had no idea. So traditionally, my family didn't share out about information. And so I don't really know much about my health history beyond my mother's history and my father's history. And so when my mom shared with me that she had the spot on her lung, right away I start gathering information to learn more about, what if this was lung cancer, those kinds of things. And went on this journey with my mother through this diagnosis, which was 4 months from diagnosis to death. And I was thankful that she allowed me on this journey with her. But I also decided at that point to use my knowledge and expertise that I was gaining in my doctoral program for the good of my community, so that I could be a voice in the community, to the community, about hospice. At that time, we weren't really talking about palliative care, but I've since learned that whenever we talk about hospice, we're talking about palliative care. And there's a lot of educating and knowledge that needs to be shared, particularly in the Black community, because many of us have been cut off from this information, whether intentionally or unintentionally. And so there's a need to be open to hearing and understanding these messages about what type of care is available to us, and especially to older Black Americans, because so many of us, and I'm in the baby boom generation, so I'll say, experienced overwhelming structural barriers and systemic racism that helped us to have a healthy dose of suspicion about healthcare systems. But there's a need for us to come together and think about how can we continue to not only receive information, but be the creators of that information and the disseminators of that information. And I know my colleagues who are on this panel today are contributing to the creation of knowledge and dissemination of knowledge and working closely with the community so that we can right some of these wrongs, meaning getting the right information that we need to feel comfortable about sharing our health information, about accessing and receiving healthcare information. I know many of my colleagues who I work with in a broader spectrum don't understand mistrust in the healthcare profession. And they're now, since the pandemic, be it good, bad, or indifferent, people are standing still, paying attention and listening to us talk about this healthy dose of mistrust and where it comes from and how important it is for healthcare providers to respect that we have a healthy dose of mistrust. But we need to work collaboratively with people that we can develop trust with, like our colleagues who are doing this work in the community, so that we can help, especially older adults who have experienced, many have experienced the type of racism and discrimination that has left them with multiple chronic illnesses, little to no access to healthcare and treatment. And collectively, I think we can begin to make some progress. And I hope the community, those of you who are in the community, are also contributing to this work, or perhaps there are some community members who are here who will gather information and see us as a resource as you continue on your journey to live healthy and happily. Thank you. I'll stop there.
Thank you, Dr. Bullock, for those very interesting and engaging remarks. Let's turn to Dr. Gray now for a 10-minute presentation.
Thank you so much. I think I want to cover three main areas. First, just really providing an overview of what serious illness and palliative care, what that means, and how families play a role in that context. And then finally, really providing kind of some suggestions for how families can serve as advocates for their loved ones who are faced with a serious illness. What we know is that about 45% of Americans have at least one chronic disease. We also know about 57% of individuals with serious illness are actually taking 5 or more prescriptions. So we have a society where people are heavily burdened with serious illness and medications and diagnoses that really do alter their quality of life. We also know that among this serious illness population, 26% of those report being denied some type of medicine or treatment that they needed because of insurance barriers or lack of insurance or inadequate insurance coverage. When we think about communities of color, there's been many systematic reviews talking about how African-American, Latino, Asian patients in particular really face kind of differences in care when it comes to serious illness and end-of-life care. For example, in one systematic review and others subsequently, we have learned that, for communities of color, these patients often opt for more aggressive or intensive end-of-life care, meaning artificial hydration, wanting mechanical ventilation, CPR, and less likely to have documented advanced care planning. We also know that for example, African Americans with metastatic breast cancer are more likely to have unmanaged pain, psychosocial distress, and unmet informational needs regarding their care. People with fewer socioeconomic resources are less likely to die at home. And presumably this is because of a lack of ability to afford or access services that may make dying at home more feasible. And also paying for private caregivers, for example, individuals who come in, home health aides who come into the home care setting for these individuals. This is beyond the ability of most Americans, regardless of color, regardless of race, ethnicity. And this is a huge problem when we think about end-of-life care for patients with serious illnesses. There is such a stringent eligibility criteria when it comes to hospice, access to hospice and eligibility to hospice care. We also know that racial minorities have lower rates of hospice use, likely due to greater mistrust, as Dr. Bullock has shared, cultural beliefs and preferences, and a greater desire to have life-sustaining therapies, regardless of prognosis, regardless of if they are significantly likely to have worse outcomes and imminent death. And one of the specialties in medicine that may not be all too common, it's one of the newer specialties that's increased dramatically in the last 50 years, is something called palliative care. And this is an area that my research really focuses on. And palliative care really seeks to support individuals from the time of diagnosis of any illness to survivorship or end-of-life care. It can be provided for people who have acute or chronic illnesses. They don't necessarily have to be at end-of-life care. It just may be for those who have a diagnosis that is life-altering. And this type of care really focuses on providing relief, alleviating suffering, optimizing quality of life, reducing stress related to the illness for patients and families. And one of the things that we know a lot about in our community is that families play a huge part in kind of how we get through stress and serious illness. And AARP, which is an organization that really supports people with serious illnesses, particularly those who are particularly the aging population. And they've done research related to the role of families related to caregivers for people who are diagnosed with serious illnesses. We know that there's about 53 million caregivers in the United States today. And what that means in a different term is that more than 1 in 5 adults are unpaid family caregivers. And as Dr. Bullock has mentioned, baby boomers is a rising demographic, a rising group of individuals that are shifting from being caregivers to actually being the ones who need care themselves. And what the caregivers do, they are a significant part of the unit of care. I know from my own personal story, I'm a caregiver for my loved one in my family, and it is a huge responsibility in helping them being able to coordinate their care, making sure they manage their medications, making sure that they go to their appointments, and also have dignity in even the changes that the diagnosis has brought them. And serious illness impacts the entire family because there's oftentimes a change in context, a change in relationships. There's rewards and challenges that are involved with it. There's a sense of knowing that you're helping other individuals, but it's also a strain financially, emotionally, socially. Oftentimes caregivers may find themselves being socially isolated from their own friends or their own hobbies because they are spending time with the one who needs care. And typically family caregivers, they have different needs because oftentimes they're patients themselves. They are faced with diagnoses themselves. And they may vary in terms of immigration status, health condition themselves, health literacy, where they live in context to the older adult with a serious illness. And when we think about family caregivers, they have a lot of responsibilities, but one of the biggest ones, especially in the Black community, is being able to advocate for their loved ones in the hospital setting. And what does that mean? That means being involved in decision-making. That means being a trusted individual that the patient knows you have their best interest in mind. It means communicating well with the rest of the care team, being respectful and compassionate, and understanding what it is the patient really wants when they are not able to speak for themselves. It also means taking notes and having careful record keeping in terms of what goes on in the clinical encounters and the hospitalizations. And also it's about managing the social service supports, meaning meal deliveries and cleaning and managing the household, but also the healthcare responsibilities of it, with taking care of IV lines and amputation and helping patients walk in their mobility and ADLs. But also there's a legal aspect, and we can talk about this in the Q&A too, that a lot of times family members, family caregivers, there's people who play different roles in an older adult's care. Some provide the medical management, some provide meals and cooking and managing the household. But then there's other aspects of that person's social circle who helps them with decision-making, and really when decisions are really tough when it comes to their health care. And that can include helping them plan for their future, helping them create living wills, and being able to be clear about what it is they want when the time comes for them to have to make those decisions. So I'm really looking forward to continue this conversation. Like I said, it's really hard to kind of sum up in 10 minutes the experience of people with serious illnesses and what it means, particularly for communities of color and the role of family in that. But looking forward to your questions and continuing the dialogue.
Thank you, Dr. Gray. I think that was very, very informative. Mildred, let's turn to you.
Thank you. Good afternoon. Well, almost good afternoon, everybody. So Dr. Bullock touched on the aspect of women having always borne the brunt of domestic work and the task of caretakers in the history of this country. And that does not stop in elder care as well. Throughout nursing homes, it is very typical to see Black and brown bodies doing the one-to-one direct care work of CNAs, of the nursing. Also, it's as Dr. Gray pointed out, there are many aspects of aging within the healthcare, social service care, and there is the community care. So I will speak on aging in Massachusetts, some of the resources available, stages of decline, and some things to really look out for your loved ones in the community before age takes away some capacity for some self-advocacy preparation. Preparation is key. So the stages of decline, what we really look for as social workers. I am a licensed clinical social worker. I work with geriatrics. And one of the reasons that most people come into nursing homes is a slip and fall, an accident that's happened at home. What are some ways that we can prevent slips, falls, accidents at home is to manage our environments, from floors to the actual space. If you've known your loved one to be a clean and tidy person for most of their life, and then you see either gradual or sudden increase of objects being brought in the house and the tidiness or the cleanliness of their environment changing, that is a red flag that something is changing within your elder or your loved one, whether it was physical or mental. There is some kind of incapacity to continue to manage their environment. This incapacity to manage an environment usually leads to slips and falls, bacteria, and infections, which we see in the skin. Then they go to the emergency rooms. From the emergency rooms, they're discharged to subacute, which is our nursing home facility. So slips and falls, managing their living environment. If you have had close contact with a loved one and all of a sudden there is a decrease in communication, one, you want to make a note for yourself. Two, you want to check and see how I tell everybody, when was the last time you checked on a loved one? Create a schedule. If you talked to your mother daily, then all of a sudden you're talking to her weekly. Then all of a sudden you don't hear from her for a month. If any of these changes are not some of a previous pattern, that is a cause for concern. If you don't already have her PCP or some information, well, let me take a step back. Everybody should have information for their loved one that they want to take care of. What do I mean by this? You and your mother have a close relationship. Do you know your mother's PCP, primary care physician? If anything happens to your mother, do you have information? I say mother because in the nursing homes, we have a lot of children who take care of their mothers. We don't see a lot of children taking care of their fathers. So I'm just going to point that one out. So do you have any information for your mother? So in case something happens, you're able to step in. Now, reverse. Have you and your mother talked about healthcare proxy? If something happens to her, do you have the right to have conversations? When people come to the nursing home, this is what my day is like. It is a person who does not have any information on the steps that it takes for one to get into the nursing home. They do not know their rights. And I get flooded with the personal stories, the physical needs, and the family relational needs. So then I have to slow everything down and go through. Thank you. Thank you for coming. I'm here to help. What is your first question? And it's usually, what is wrong with my loved one? How am I supposed to help them? I didn't know anything. So we start off with the basics. I don't know anything either. Let's see what we can have together. So If I give anybody any advice, and I'm sorry, I'm so nervous, I'm scatterbrained right now, but bear with me. When people come in and I have to reel it back, I start off. Healthcare proxies allow people to talk to medical officials only when the person is incapacitated and they are not able to speak for themselves. So if you are not the healthcare proxy and the person's able to say they want one, let's start there. And then we can share certain medical information. That's how it goes in the nursing home. When a person comes into a nursing home, within 2 days, we have to have a family meeting. In that family meeting, a person is able to say what they would like to share, who they would like to share it with, and we discuss why they came into the nursing home and their discharge plan. This process unto itself seems easy, but we then have to evaluate how the person functioned prior at home, what their medical diagnosis will allow them to do within the rehabilitation time, whether they need occupational therapy, physical therapy, and or speech therapy, and whatever medical interventions are necessary. There is usually a gap within not just the Black communities, but well, specifically for the Black communities. There's a secrecy when it comes to their homes and cleanliness. If their homes are not clean, they don't want individuals to come into their homes, which makes me go back to the changes in behavior in hoarding. So sometimes within our rehabilitation, we are impeded because they cannot go back to their homes because of cleanliness. So within the Black community, there are steps for certain organizations to come out and clean before people are discharged from hospitals and or nursing homes, so that we have a better turnout of people returning to their homes. And I think I'm going to stop there.
Thank you, Mildred. Thank you to all of our speakers or panelists for their presentations. I'm going to switch gears a little bit and just present some questions for our panelists. You've all talked about different areas of aging and caretaking. And so I'm wondering, what key questions do you think caretakers should be asking of healthcare providers, of facilities where their loved one may be receiving care or might be receiving care? And anyone who's willing to answer that, I guess, of the three panelists, please feel free. I can't hear you. Can everyone hear her?
There we go. Is this better? Sorry
There we
about
go.
that.
Yes. Okay.
So I was saying anything related to family, I'll go ahead and kickstart us off if that's okay. I do think that whenever patients and families have a clinical encounter, there should be questions that they should have prepared. And some of those questions can include, why are they coming into the hospital today? Why are they being seen today? As simple as that. What is the added benefit of this plan of care? What do you, as the care team, expect to see when we opt for this course of treatment? Any possible side effects that we should expect? And then more importantly, too, as Mildred mentioned, how does this recommendation in terms of care, how does this change the patient's ability to function independently and maintain their own quality of life? And what are the options if we choose not to do this? I think one of the things that we have to remember as patients and families is that we have the option to learn more about the rationale behind care team recommendations. And if in determining whether it's suitable for our particular circumstance. Is this test necessary? What's the average recovery time if we do X, Y, and Z? What cost can we expect? Is there any written information that we can take home to be able to process everything that was discussed today? And I think one of the most important questions is, if we think of questions later, how can we contact you? Because it's so often that you get patients and families get so overloaded, and also the time is really short with their care team provider. So being able to know, how can we have follow-up questions? Who do we contact? Not can we, who do we, how do we contact them? I think that is an important question, because it can save on unnecessary readmissions back into the hospital setting. It can it can help to mitigate safety concerns, and it helps the patient and family feel empowered, because they know that they have someone that they can reach out to for follow-up questions. So those are just some ideas that I have.
Dr. Bullock or Mildred, do you have anything to add to that about some key questions that caretakers should be asking?
When it comes to, can you hear me?
Yeah, we can. Yep, we got you.
When it comes to nursing homes, so COVID has changed everything, from the number of nursing staff to the use of agency nurse. So most nursing homes do not have a continuum of care for a lot of the nursing staff. So that's a question. What's your staffing ratio? Because you want to know how many people would be able to take care of, say, 40 individuals on a day. So if you have a loved one who's incontinent and they're going to be soiled for much of the day, you want to make sure that they're able to be cleaned so there's not skin breakdown. So also, you'd want to know what was their last survey. A survey is done every year by the Department of Public Health. You want to know, what was their rating? Were they a 1-star, 2-star, 3-star, 4-star facility? In those surveys, you're able to see any deficiencies. Deficiencies are deductions because they were not able to meet a state mandated guideline. You want to know their falls. What number falls? Are they fully staffed with a dietitian, with a rehab department? Who's in their rehab department? Do they have occupational therapy, physical therapy, and speech therapy, or are they using an outside agency? Within Massachusetts, it is very clear. Nursing homes that have endowments are run much at a higher level currently post-pandemic than prior. Prior, it was more of a even level playing fields, but those that are privately owned, at this time, there are nursing homes shutting down every week, it seems like, because of funding, state funding, and the guidelines. So I know that was a lot, but I got to give some context as to why.
That's helpful. Thank you very much, Mildred. I just want to acknowledge that one thing I appreciate about this panel is that we have this range of perspective. And so whether it's inpatient or nursing home, and so I'll just speak to the community level interactions, meaning it's great if you feel empowered or you have the voice to ask these questions. I wish every older adult did and every caregiver did, but many of the people I work with are hesitant. Not that they should be. Again, I wish that everyone felt empowered and could bring their list and would sit down and say, what about those tests and how many? And there are some who do, and it's great. I tend to work with those who haven't quite found their voice yet, or who worry about, if I ask too many questions, what will happen. And I would like to dispel any kind of myths about anything happening to you that will diminish your care because you ask questions and you speak up. And I can speak from the bedside as a caregiver, having been to appointments with my mother. And I think the providers sometimes are so focused on, we have a standard of practice and this is what we have to do, rather than seeing each patient or family as the individuals they are. So they usually, as Dr. Gray has said, you only have a limited amount of time. They're trying to get their questions answered. They're trying to move on to the next thing to see what the next level of care will be. But if you're at the bedside or you're the patient and you're nervous and afraid about what's going to happen. My health has been compromised. What can I do? It's helpful to have a support person with you. And sometimes we hear people say that, well, only the patient can go in, or we can't have another person with them, which is really unfortunate. And we're working in healthcare settings to try to do better about that and to educate clinicians. And I know I sit in various spaces where we are developing curriculum, doing in-service training, grand rounds, et cetera, trying to get the healthcare providers, the clinicians, to see that we need to do something that's culturally responsive with our patients. So if a person says, I want my daughter to come in the room with me, like, why can't we make that okay? Versus saying, well, you wait out here. And I know with my mother, when the oncologist said, I need to speak alone with your mother, and took her in a room, my mother wasn't going to speak to someone she didn't know. And, so about anything that she was really feeling that she thought was sensitive. And so, as we heard earlier from both of the panelists, that it's important to have relationships. Many older African Americans that I work with, and this could be an overgeneralization for many people, but for whom I work with, they don't have long-term relationships with physicians. When they go to the hospital, sometimes it's the emergency department. When I worked in the emergency department, which used to be called the emergency room, but now it's a whole department. In the emergency room, when you take a loved one in, or a loved one goes on their own, or a person goes to emergency room, it's an acute, like, they're looking for the acute problem. Let's try to do something about the acute problem. And oftentimes it's rapid fire. Where older adults sometimes need that information to be, well, slow down, let me understand it before I make a decision. And if it's serious illness care, it's all happening so fast that before the person can even, pull themselves together, they're expected to move on to the next thing. So having someone with you, asking the providers, can we go in the space with my mother or my whomever, my loved one would feel better if I was there to help her to think clearly while she's ill. So I just want to encourage you to ask providers for what you need, because unfortunately, they may not be cued into the fact that your loved one isn't going to give them any more information if they don't have a support person or someone they trust there with them. And so that's my contribution to the discussion about, how to approach the clinicians or providers when you're in those care settings. Thank you.
I guess a
Can I
follow-up.
just
Oh, go
add
ahead.
to
Yeah.
that? Can I add to that? Dr. Bullock mentioned the relationships that Black families, Black patients typically have with the care team, in terms of just longevity. But I actually want to just add to the fact that these patients often experience a sense of deference to the care team members. So when it comes to decision making, they often ask the care provider, what do you think? I don't know. Why are you asking me what I want? A big aspect of palliative care, for example, is understanding what the patient and family want. But when culturally, that is very different for a lot of my family members. We're like, what do you mean? What do you mean? You should know. You're the doctor. You've had this training. So I think we want to make sure that those patients do not feel neglected or feel that it's up to them and the provider doesn't care. It's a kind of a shift to we want them to know that we want to hear their voice, their opinion, and we're not going to be neglecting our care because we're asking them what is important to them. So it's kind of a cultural belief and deference that kind of often happens in the Black older patient population. So I just wanted to shed light on that.
And if I may, I just want to follow up, because I think it's helpful to do that as well, which is, my academician perspective will be that, we're teaching clinicians to do, there's these standards of what we're saying is best practice. And so best practice is to ask the patient, what do they want? But culturally, the patients don't know that we've decided that that's a best practice, right? And so the patient is coming in thinking, I'm going to see an expert. And the expert's going to tell me, once they run these tests or do these things, they're going to make some recommendations. But best practices have shifted in the education systems of clinicians, whether that's medical school, social work school, nursing school, whatever. And so this idea that now the patient is the expert is throwing off some of our Black patients, because if I'm the expert, I don't need to come to see you. So it gets very confusing when we start to talk about cultural humility, which is the concept. We're not going to go there now. But the point is, to be culturally humble, clinicians are saying the patient is the expert. Well, if the patient is the expert, what are you there to offer them? So there is this cultural incongruence. So I just wanted to add that while we're talking about the shift, because we as panelists know what's going on behind the curtain. We know that the clinicians are well intended. We know that we keep getting these updates on, what's best practice and what's patient-centered care and goal concordant care. Well, the patients aren't in the classrooms with us learning these things. So they don't know what we're talking about. And so I think we just have to be reminded, and for the patients or the caregivers who may be participating or listening to this webinar, I want you to know that we understand that you don't get this language. We're co-creating this language and then bringing it into the care setting and expecting that you are going to know what it means. And that's a flaw, in my opinion, in the system. So just want to acknowledge that.
And how would you advise somebody who doesn't believe that they are getting the right care? I mean, so even if they are, advocating for their parent, if it is, and they just don't feel like they're getting what they need, or they don't feel like they're being heard. Do you have any strategies for addressing that?
I'll comment about this, because I was just in a meeting yesterday where we're grappling with developing a tool, and I'm working with some researchers that Dr. Gray works with also. And we've done what we call these race dialogues, where we've had participants from the community to participate in focus groups to tell us about racialized experiences in healthcare. So, we reach people in the community, ask, has this happened? Have you felt that you weren't being treated like other patients when you were in the care? And we have this data that we were going to use to develop these tools that clinicians can then take into the care setting and ask the patients, like, do you feel you're being treated fairly, et cetera? The challenge is, what patient is going to tell their clinician, doctor, nurse, social worker, I really feel like you're not doing a good job of providing care for me? It's complicated to get a person to feel comfortable enough to tell you that in this system of care that they're dependent on right now for their care, that somebody's not treating them well. So I would just acknowledge that it's a complicated thing. And maybe some of my colleagues on the panel, have a magic wand or ingredients. I would really love to hear about what are the best ways to help a patient and or a family member to feel comfortable to critique the setting or the provider that's caring for you.
I'll just say that patients have options, and patients need to know that they have options. That's kind of like point blank, that, if you're not receiving the care that you think you deserve, you got to move forward. You got to, that's why we have internet nowadays. That's why we have telehealth nowadays. The provider doesn't have to be right next door anymore. I think I'll pause there. Mildred, do you have?
Yes, so just like in the nursing home settings, there are options. Grievances will always make nursing homes better. I just had a family who was unhappy with care, and I started an investigation, found out where the person wanted to go, and started researching so a move can happen. Every resident in a nursing home has rights. It's federally mandated, just like in any hospital, just like any care, community care center. You have rights to your care, to have your voice heard. And that is very different for a lot of the older generation. And just like Dr. Bullock said, it's great when you can have an advocate there with you as well. So I just saw a question pop across. So having somebody to come with you really helps for care. I'm sorry, kind of threw me off.
If I may circle back, just because I started the question of what can we do, I only acknowledge that because I don't want patients to feel that if they can't do these things, there's something wrong. Like, it's difficult. It's all I'm acknowledging is that it's difficult to find a way to provide this feedback. And I would add that the ethics committee, which we don't think about often, like if you are less inclined to speak up when the person in front of you, many care settings will have a posting somewhere in the elevator or throughout the institution or organization that speaks to ethics committees. And it's been my experience that any person can call and look for those postings throughout this. They should be there, public facing, letting people know what they can do if they felt that they've been treated inadequately or unfairly.
So in the nursing homes, these are called our ombudsmans. They cover general areas. So like I said, any grievance, if you have, you can go to the Department of Public Health. You have the right to go as far as you need to get your needs met. So within any facility, there is the social worker. Through a grievance report, you can go to any nurse manager, an administrator. Outside of that, the ombudsman, and past the ombudsman is Department of Public Health. So there are stages, there are levels. We just always ask that you start at the bottom and work your way up, but go as far as you need to for your needs to be met.
Thank you. I think that was helpful guidance for people struggling with those issues. I had a question that came in on YouTube. Somebody asked, how do you know when it's time for your parent to move in with you? And what do you do if they're resistant to that idea? Miller looks like she's talking.
Oh, sorry, still muted.
There you go.
So
yep.
There are levels of care. So if in-home is not working because of whatever reason, the next step could be respite. So respite is not really used, and I don't think many people know about it. If you cannot need time, space, you as a caregiver, you can contact a local nursing home and see if they have room for your loved one to stay. Insurances usually pay, I want to say, up to a week. It depends on the insurance, so that the caregiver can have some time, so that there is not that caregiver burnout. Or you can use a respite visit to see how your loved one will do in a facility. So after the respite, there's independent living, where there are other elder adults or individuals with disabilities that are in a facility, but there is someone to care for them. They can leave the facility, they can have their own individual lives. Assisted living is the next level, where there is, again, communal living, nursing care on site, and then skilled nursing facility or a nursing home rehabilitation center is when there are extreme medical needs, or we just got some people who came from, we have some individuals who are admitted and they have not quite complex medical needs, but they just don't want to go home. They like the nursing level of care. They like the routines of the nursing home. So they're also eligible to stay there. So it depends on your loved one's independence, their cognition and ability to make safe decisions for themselves. It's also dependent on a person's ability to take care of themselves, wash themselves, clean the house. So if you see that these things are changing, you can always reach out to the aging service provider in your area. In Boston, there are 3. There is Ethos, there is Boston Elder Commission, and one more. It's escaping me right now, but there's 3. You can always go to bei.com, Boston Elder Info, and that will give you information about the levels of care, the services available in your vicinity, and how to do a referral so that a nurse or a case manager can how your loved one is doing.
And one thing, if I may add to the question of how do you know, it's always a good idea to have conversations as early on as you can before there's a decline. So I would encourage you to start talking with your loved ones, family members, about what would they want to have happen if there comes a time, and there are ways to have those conversations as early as possible, so that if and when the need does come, you have some idea of whether this would be a preference, whether you would make the decision for the person to move in because you don't have other options. What would that mean for you and your family if you moved a relative in? All of those kinds of things, I think, when possible, to begin the conversations long before the person is in need, if possible.
And I love that, Dr. Bullock. I love that, Dr. Bullock, because you mentioned how we have to have those conversations early on, and that is something we often do in our community. The total opposite. We do not talk about it. Sometimes, if you don't, we think if you don't talk about it, it will not happen. This person will not get sick. This person will not need, home health aides. Will not have to compromise their independence. Like if we don't speak it into existence, we won't. It won't happen. So that's up to us as kind of clinicians and leaders in these fields to really kind of empower people to know that these conversations must happen to really make everybody's life a little bit more peaceful when the time comes. And so I think that is an important point to make. I think when we're talking about loved ones, there's a question about loved ones who do not want to be cared for by the caregiver, and I assume the caregiver maybe a family member, a friend in this question, or I guess the parent. I think we have to ask, well, what are they worried about? What concerns them with that? Because it's probably not as it's probably a little bit more contact or more contextual than we may think at first. They may be worried about XYZ, having to relocate to be with that caregiver, having the caregiver come in and encroach on their space. So we don't know what that means when they say they will refuse. I think getting more information, just to answer that person's question, is important. Getting more information from the patient early on while they're still cognitively intact to understand, why they refuse, what options did they see. They may say, I'm fine. But also I think thinking objectively too, you have the stove that stays on and you're not at home, or you keep the door unlocked. There's safety concerns. I think as the potential caregiver of that person, writing out a list of things that are brewing, if you will, that's a safety concern. But it first starts with conversation. It starts with, what concerns you with having someone come and help you.
And to the point, just to emphasize a couple more things, is that the loss of independence can be very scary to older adults. So the idea that here I've taken care of my family, sometimes if the caregiver is an adult child, I've taken care of you, and this idea that now you need to be taking care of me can be overwhelming. Also, the loss of independence by having someone come into their home. And if that person is a quote unquote stranger, that's how many older adults, like if they don't have a relationship, if it's a home health aide, to the point that Dr. Gray just made, the fear of having a stranger come in and someone I'm supposed to trust to care for me or to be in my home and in my very personal space can be very overwhelming for an older adult, especially when their health is compromised and they realize that they're not as alert as they may be, or maybe as able to make these decisions, or to see things that might be happening can really be overwhelming and a difficult decision to make.
Great, thank you.
So also,
Go ahead.
So what I will, another is the caregiver congruence, because everybody is not a good match for being someone's caregiver. And some people, it's hard to accept that you're.
Looks like we may have lost her, but we have several questions in the queue, so I'll just move us along. We have someone who asked, how do you know whether a loved one may need to change providers, and how do you navigate that change? Looks like Dr. Gray, maybe?
I'll definitely start my response, then Dr. Bullock can jump in. I think it's kind of like with anybody that we love despite their age. If they are not looking forward to the doctor's visit, that's gonna, it's kind of like anybody along the age spectrum. If they're not looking forward to something, that's kind of a point that we need to take in mind. So so the question is, what do we do if the patient doesn't want to go to be seen by a provider? How do we know if that's not a good match? If they show a little bit of, nervousness, anxiety before the visit, if their energy, mood shifts after the visit, if they feel overwhelmed, if they feel not heard, not seen after the visit, that is a big red flag. If they feel rushed, if they feel judged, because we talk a lot about with older adults, we think about dementia and cancer, but there's also other stigmatizing diseases and health conditions that patients may feel that the doctors are not supportive. So that in itself can really impact the relationship. So I think anything that really shifts the mood, the energy, the feeling that the patient or family has in those conversations with the care team and the interactions, those are big red flags, and what to do about it. I think, it's interesting. I like for nurses, I'll speak to, and I'll say nurses are great allies for patients and families. We see a lot and we hear a lot in terms of what patients and families share with us in between visits, after visits, concerns that they have, and really getting other care team members' opinions about options that they have, I think is really important.
And I would echo that sentiment, as Dr. Gray said earlier. You have options, patients have options, and they have the right to exercise their self-determination around whether it's a good fit. And if they have health insurance, which I hope they do, the benefits managers for health insurance companies generally will help a patient, or if you are the healthcare proxy for a person who needs to make a change, and if you contact them to say, we don't feel that we're getting adequate care at this place and we want to choose another primary care provider, they generally will give you the instructions or guidance and help you to do that.
Great. We have several questions about financing, like who pays for this type of care? What can caregivers or what can families expect insurance to cover? What is there state coverage? Is there local coverage? I mean, can you speak a little bit about financing all of this, and is it variable from person to person?
So generally, most people, as long as you are within a certain bracket, insurance will cover for nursing home care. What becomes sticky is insurance covering for short-term rehabilitation. That's where I see a lot of people in our community struggle because of factors as Dr. Gray, Dr. Bullock has spoken of, income, previously savings to be able to do certain things, the lifestyles lived previously. A lot of people of our community, Black people, cannot return home because they cannot maintain. So being inside of the facility, if you have like Mass Health Standard, the question is, if something happens, how much rehab will you be able to have and how long? So Mass Health pays for hospitalizations within the nursing home for long-term care, as well as many national United Healthcare, Senior Whole Health. Another question, going back to what questions we would ask, in looking at nursing homes, I would ask the admissions person, what is the best insurance for my loved one to receive the best level of care, especially if they're going there for short-term rehab. And I was cut off before when I was talking about caregiver congruence. Sometimes it's hard for individuals and family members and caregivers when they don't mesh well with their mother, their father, an aunt that they always adored. Sometimes someone else being a caregiver can be a godsend in that individual's life. So some people don't do well with strangers, and other people feel more comfortable with a stranger taking care of them than somebody who has seen them regress over the years or become ill towards the end of their lives. So I just wanted to point those two things out.
Thanks. Yeah, I want to just focus a little bit more on the question of finances. I think that's a big issue. So we talked a little bit about insurance, what insurance might pay. Is there a patient portion that a patient or a patient's family would be responsible, and what does that look like?
I'll comment that my experience has been that it depends on the type of insurance that a person has. Sometimes older adults might have multiple plans. So there's a Medicare Part A and a Medicare Part B. And then some people have, in addition, a private plan, meaning that they've worked and they've sort of quote unquote paid into a plan and they get that in retirement. So it really depends on the plans and also where they're receiving care, because some settings, I'm trying not to use the word institutions, but some settings, care systems accept certain, like for example, a provider or system might have, especially if it's small, a certain number of Medicare patients it can see, and the wait can be really, really long if they're trying to balance between how many Medicare patients they have and how many mass health and other kinds of insurance. I mean, those are things that go on behind the scenes that the patient should probably never know, because ethically the decision shouldn't be made based on that. The decision should be made on who needs the care and whether there's a bed available or space available. But the reality is the insurance can dictate that. And I'll give an example. When I worked in the emergency department, we would call the health provider to ask how many days can we get for this patient. And depending on the number of days that we were approved for the patient, we would start with that number of days. So they might say the patient can get 3 days, approved for 3 days, and then the case manager has to call back and get more days. It really depends on the plan and how, if you're paying with a private plan or other types of plans. That's been my experience in inpatient settings.
Yeah, a good
Yeah,
question.
and I must
go ahead.
say,
Go ahead. Yeah.
I just want to say, just as from a research standpoint, this is one of the things that I truly care about. A lot of my work focuses on wanting to support families after discharge by helping them before discharge, because once they're discharged, their services and supports, access to those services and supports become just limited and based on income and health conditions, et cetera, availability of clinical care teams in the area. And so it's critical that we make sure that patients and families utilize being in the hospital for any condition while they're in the hospital. That's being able to really get connected to the social workers beforehand, to the psychologists beforehand, the nurse practitioners beforehand, because as Noda has mentioned earlier, the lack of continuity of service of care based on different settings is truly just so devastating in this country. And people really have so many gaps because of this. So one of the resources I just put in the chat is about, how do you find resources in your area? Because oftentimes what's concerning patients and families is not necessarily the finances of health. It's about keeping a roof over their head, keeping electricity, keeping the fridge open so that they can put their insulin in there, so they can be medically compliant. It's about figuring out how to have the transportation to get to that follow-up visit. So sometimes it's not even about the actual health medical condition. It's the things that are compromised sometimes because of that diagnosis.
And in regards to healthcare, I just want to say there's a construct now that's called financial toxicity. I mean, so many people are experiencing it when they are trying to provide care that, as Dr. Gray said, there's continuous exploration on understanding it. And people do worry about losing everything. And sometimes it will prevent people from even seeking the care that they might need because of not knowing, like, am I going to lose my home if I have to get this care, and those kinds of things. And there definitely needs to be greater sort of dissemination of information. So I appreciate the resources that have been shared thus far in the chat.
Yes, because, well, to be in a nursing home long-term care, you cannot have your name on any house, right? So it is one of the most egregious things to me that Black families, you work your whole life, your grandma thinks that they can hold on to this house and leave it to somebody. Grandma or grandpa needs to be hospitalized. They need to go to a nursing home. That house has to go. It has to go in someone's name, or we see some predatory practices of like organizations going in and swooping up these houses because grandma and grandpa they were the only ones who could take care of that house. That was their house. No one else in the family financially fit to be able to buy that house or take care of it or maintain it. So that discussion early years, what's going to happen to my home? If something happens, what's the next step? How are we going to keep this in the family? Or are we going to strategically plan? It's not a last minute. Now everybody that was in the home now has to find a new place to live, because we've seen that as well.
And another barrier too is the caregiver supports, I would say, for some people, because while fortunately in Massachusetts, there's the option for caregivers, informal caregivers, to receive payment for caring for an older adult, but they have to, quote unquote, be in the foster care system. And some people see that as a barrier. There's a link that will be provided in the slide, but if you read this information, it talks about, yes, payments are available to caregivers, but you have to go into a whole system of care. And some people feel that that's not the way they want to care for their loved one, with someone else, kind of through a system like a foster care system.
Can you all address what happens when a parent refuses the aid or intervention of a caregiver?
I'll respond based on my experience, and other people may have different experiences, but most people are familiar with child protective services of some sort. It's called different things in different states, but for adults it's different. And there's a fine line, because people have a right to self-determine. People have a right to say thank you, but no thank you. Or if they don't say thank you, they just say, I don't want it. Like, there's a patient's right to determine, which is a legal act from 1990 or 91, that patients can refuse care as long as they have the capacity to make that decision. They can say, no, I don't want it. And so others who care about them, loved ones, might say that they're refusing this care and they really, really need it. But it's very difficult for someone who does adult protective services to engage in an assessment that will result in saying, no, this person can't live like this, because there's all types of qualities of care and we would want the best, but who gets to determine that? So legally, people can refuse care as long as they're not doing what's determined by the legal term of harm to themselves or harm to others. And that's what makes it's really difficult, because unlike children who aren't of the age to make the decision, adults can make the decisions to forego treatment.
Yes, and I think about my own family. One of my grandparents actually was about 95 or so, diagnosed with advanced cancer. And, he loved being outdoors, loved anything related to nature. And when he was in the hospital, clinicians didn't know that about him. I think when patients and families have the opportunity to share with the clinical team about who that person lying in the bed is, who they are as a person, that in itself will help everything else to make sense about why this person does not want this G-tube, or does not want this PICC line, does not want to lose a leg. Because maybe they used to ride horses and, not having a leg kind of, it means something to them in terms of their identity. So, I think sharing a bit about who these patients are as human beings helps to put many things in context, including why they may refuse care. There may be just a reason it's more than just refusing. There's oftentimes, if we just listen to their stories, there's a reason that's deeper than that for them.
And another comment about that quality of life may just be what they anticipate. For example, I'll use my mother's example. My mother refused chemotherapy. We might not think about who are the people, like, why would someone refuse chemotherapy when they offered it to her? And she said that she would prefer to have the quality of life she had then than the quality of life she was anticipating she would have with chemotherapy. And what would that be like, to have a port and have to go and, she worried about, well, I lose my hair, whatever it means to them. Hair doesn't mean the same thing to some people. To some people, the idea that they would lose it, the idea that, they would be sick for these days. And so she opted not to have chemotherapy. It can be difficult for families. We might want to go to someone and say, but she needs that chemotherapy, but they have a right to refuse it.
Mildred, I would love to know what you're thinking right now.
Well, all of these I once walked into a room of a cancer patient, and I talked about his discharge plan and everything, and he was very lighthearted. And it wasn't until later in the afternoon that I met members of his family, and they said that he always used humor to hide his real feelings. So, as you just said, it's important to really find information from family members so that you can give the best possible care. Because in the amount of laughter that he gave, if that was any indication of what he was feeling, my decision to then offer up some psych social services for counseling was spot on, because this was very traumatic for him, the information and him going home into the community. So another aspect has been talked about is that sometimes when individuals come into a setting, they receive care that is it is individualistic and it's very supportive. And sometimes they don't want to go home into the community, where it can be much more harsh. They don't have persons that check on them every day and provide an environment that is not only medically safe, but emotionally safe and consistent.
Can you talk a little bit about support that's available for caregivers themselves to support their own emotional, mental, physical strains that they might be experiencing from caregiving?
Well, on Boston Elder Info, they do have a section, like I said, referrals, and there are caregiver supports through that system. I follow an individual, Jacqueline. She started a company, Mom of My Mom. Her mother had Alzheimer's and would refer to her as mommy. She passed away about a year now. And she would always refer to her daughter as mommy. And that was jarring for her. So she started recording her story. Her website, momofmymom.com, has a plethora of information for caregivers, specifically for caregivers. The experience of a caregiver is a multifaceted one. It's heart to heart. It is you are taking care of the person who wants to take care of you. You had one vantage point of this person, and now you have another. And that shift is very jarring, especially depending on a diagnosis or a prognosis of that individual's life. So caregiver supports, every community has one. For Boston, Boston Elder Info would be the best and easiest way to find caregiver supports in your area specific to you.
Yeah, and there's Dr. Gray put some helpful hotlines in the chat as well. One question that came through is, earlier we were talking about potentially having to file a grievance if you don't believe that your care has been satisfactory. How do you avoid potential retaliation, if you file a grievance? In other words, like if the doctor or the nurses take action then against you or give you poor care, do you have any ideas or strategies for dealing with that potential?
I want to make sure I understood the question. If there are grievances, how should patients and families deal with that? Is that right?
Well, if you file a grievance, how do you avoid retaliation from medical staff for filing the grievance itself?
Well, from a clinician standpoint, we are obligated legally and ethically not to reprimand patients and families for their grievances.
Yeah, I would say I agree. And if the person feels that and I guess it would depend on whether they're in the hospital setting currently, or they filed it otherwise. So in terms of the way to respond, if you're in the hospital and you file a grievance while there, and if you start to feel that the care's changing, or people stop coming to your room, or now no one wants to come in, and those kind of things, to the point that Dr. Gray made earlier, you have options, and maybe you'd want to be transferred from that hospital if you see that your care is changing or shifting, but you should follow up with those whom you filed the grievance with to also let them know. And now I feel that something additional is happening. If you're in the hospital, most of us would say that there are protections in the system to make sure that wouldn't happen. Because if we're on the receiving end and someone has complained about us, we don't want to do something further. It's kind of like our license is on the line. I mean, people talk about credentialing and, why do we have to be credentialed and licensed? Well, part of that is to protect the patient as well, because if you mistreat a patient, if a patient files a grievance against you, your license is on the line. And so without those credentials, license boards, then sometimes people do kind of go rogue because there's no oversight. But one of the good things I will say about licensure is that you can lose it and not be able to practice. So that's one protective mechanism, whether the person's inpatient or outpatient. Their license is tied to an oath that they've taken or a code of ethics that says they will treat patients well. And if you file the grievance and there's evidence of that, they can lose the right to practice.
So in a nursing home setting, as I said previously, grievances all create investigations. And from that investigation, Department of Public Health can say, we need to come in and look at everything. So if you feel something, write it down, record as much documentation as possible so that everything can be followed up on, because it must be by just guidelines. And as far as retaliation, if there is retaliation, then you can respond to that legally or however you feel fit. But then from our state, as doctors have already said, you can lose your license, lose your job, not be able to do anything in that state and have to start all over somewhere else. Hopefully they wouldn't, though.
And I want to remind, Black patients and families, our community, I want to remind us, don't be caught off guard in trying to avoid being not aggressive and not not a complicated patient and family. Don't try and avoid that label. But so take the write the notes, write down the questions, take the pictures, get more information about the care team. Do all those things because you're an advocate for yourself, your patient, your loved one who's the patient. So don't be too worried about trying to be a pleasing patient and family. I don't know if any of my other colleagues can.
Yes, trying not to be that one, the angry, aggressive, the microaggressive one. We're okay with that, micromanaging your loved one's care. I understand you're not the doctor, but what you're trying to convey is your concern. And what you're trying to convey is that you're present. I understand that. We will always, not me backtrack, I will always understand that because I understand the behavior is not always the representation of the feeling behind that. And any good social worker, any good doctor will understand that your rage has nothing to do with them, but everything about your feeling about the care for your loved one. And once we start there, it's always good on this end. And what I hope is what people take from this is advocating for your loved one will get you what you need. Not just them, but you as well. If you don't speak up, it doesn't have to be a loud shout, it could be a whisper. We can then meet you and help you unlearn or teach you new materials to not just help your elder or their loved one in the moment, but to help you in the long run, because we all age if we're blessed enough. And in that age, everyone's going to need some help at some point in time. So as we talk to families, we always hope that it's the ripple effect, that you'll take this information, apply it to yourself and those around you, and it could get larger and get bigger and affect more within our community.
Thank you. And just being mindful of the time, and I think I'm going to turn it over to Dr. Robert Motley to provide some closing remarks. Dr. Motley is an assistant professor at Boston College School of Social Work and also oversees Boston College's racism-based violence, injury, and prevention lab. Dr. Motley?
Yes, yes, thank you. And again, I definitely want to thank again the panelist and moderator for providing what I feel was an enriched discussion on how Black older adults and individuals, particularly within their support system, can sort of overcome some of the barriers to healthcare that, you know, a lot of us in themselves may face. I also want to note that, you know, I know it was unfortunate that some individuals took time to try and sabotage the event, you know, through hacking our chat with a lot of racist remarks. But, you know, again, we apologize for that. We were able to get right on top of that. But this, to us, really just goes to show why this conversation in this context is really, really necessary. But also, I just wanted to, I think, you know, we learned a lot today, and I just made some few key highlights or takeaways from the conversation. I feel that given the population size of our baby boomers, we are definitely going to see an influx in individuals who are in need of healthcare. And what from Dr. Gray was pointing out was that, you know, 45% of these individuals will have a chronic disease, with 50% or more taking a lot of medication, 26% being denied access to care for a variety of reasons. I think one, she said, being insurance coverage. So it's important for us as individuals, as we all are going to age, that we really know our family's medical history, and that we plan for long-term care, and that we do it early. We also have to pay attention to some of the red flags. I believe Margaret was talking about some of the red flags being a decrease in communication or changes in upkeep of oneself or their household. So we need to make sure that we're paying attention to that. But also, more importantly, we have to do our research on these assisted living and nursing home entities so that we are informed as much as possible about where it is that we're taking our loved one to receive care. And lastly, do not be afraid to file a grievance on behalf of your loved one when you're thinking something is going wrong or they're not receiving the care that you feel that they should be receiving at these places. And so those are some of the key things that I wanted to highlight that was shared by the panelists through their wisdom and experience and expertise. And then just two more announcements. I know we should be having an evaluation. There should be a link for that in the chat that we ask all of you all to fill out. And then lastly, there's another upcoming event that I would like to share the flyer. Oh, they have it on the screen. Okay. Yes, this is a men's group that will be taking place, and this is facilitated by John Granger. So this is also being sponsored by the Hope team. And so Black men here will have the opportunity to experience both community and support, process through day-to-day success as well as struggles. And I feel that this is really, really important, particularly for Black men in the Boston area. And so with that said, again, thank you all. And I'm sorry, I said Margaret. Did I say, I believe I said Mildred. I'm sorry. I should have said, sorry for letting this out, but thank you all again.
Thanks, everyone.
Thank you for having me.
I believe there's a resource page as well.
I think it was going to be shared on the screen, the slide.
Yeah, I know we do. Yeah, we did have. Okay.
If you complete the evaluation, there's also be a space for you to include your email. So we can send you this resource page, the recording, as well as all the links shared in the chat.
Okay, well, I think that concludes. We finished up 2 minutes early. So unless anyone has any other closing comments or announcements. No, okay. Well, that concludes our event. And again, thank everyone for attending and be safe out there if you have to travel with the weather that's going on in Boston. But take care, and we look forward to hopefully seeing everyone at our next event.
Thanks.
Thank you all. Thank you all again for being with us today. Thank you so much for this informative discussion. Please fill out the evaluation if you received it. If you're watching on YouTube, please check out our website, www.wecanbewhole.org. Please check it out. You can get the information there. We just thank all of our panelists. We want to thank also our facilitator. Thank every one of you. Thank every one of you for today. And again, we apologize and we're sorry that we did have someone on here who decided to, and this is why we need to do these events, because we have folks who don't want us to get the access and get the information and want to do some racist and ignorant things, and we can call it what it was. But we thank you all again for being with us, and thank you, panelists. Have a great day. Oh, one more thing. Whole does have a caregiver support group. We're launching our second one in May. We have started one, so we're launching our second one in May. You'll hear more information about it where you can sign up. But thank you again. Have a great day, everybody. Bye-bye.